Hello, everyone. Welcome to White Coat Blueprint. I'm your host, Sai, and today we are going to be exploring a specialty that not a lot of people know of, yet it's so important and it's absolutely vital in treating children with serious illnesses. And I'm excited to be joined by Dr. Dianna E. She is a palliative hospice and palliative care specialist at Dell Children's Medical Center here in Austin, Texas. Hi, Dr. Yip.
Hi,
How are
Sai.
you?
I'm good. How are you?
I'm doing good. Thanks for asking. Thanks for being here. Thanks for taking the time. And to get us started, could you tell us a little about palliative care? What is palliative care?
Yeah, I think that's such a good question, and often this is the thing that I am talking about with patients when I first meet them. And so I always like to start with palliative care is often comes from the word palliate, which simply just means to ease. And for every patient, for every family, that is so different and unique and individualized. And so, really, palliative care is a discipline of medicine that is looking at somebody who is the whole person and wanting to understand their values, their goals, who they are as humans, and really focused on comfort and how do we give you the best life to be living with what you're having to deal with.
Thanks for sharing that. I think we just broke the major icebreaker here because a lot of people, they don't understand what palliative care is. And when people who are facing serious illnesses are when doctors ask them, do you want to take palliative care? They're usually very confused about what it is. And I think it's really important to know what it is and to be informed about the specialty. But I also have another question for you. So, we often hear terms like hospice care, palliative care, and not to mention comfort care used interchangeably, and many people actually, including me, find it really confusing. So if you could differentiate that for us, please.
Sure. And I just want to say something or kind of talk about something you mentioned, Sai, which is how sometimes doctors are saying, would you like palliative care? And I think that's so interesting because when we think about other disciplines, other doctors, like a cardiologist or a nephrologist, most doctors do not present it as an option. They're like, your heart has this problem, so I'm going to send you to a cardiologist. And everyone goes, okay. But in palliative care, there's this interesting divide where there's kind of this I don't know, should I have permission from a family? And my hope is at some point physicians can understand palliative care so well and be able to speak honestly to their patients. This is why I think you need palliative care, and this is why I'm referring to you.
Thank you so much for highlighting that, Dr. Yip.
Yeah. I think it's because a lot of physicians still feel like palliative care is hospice, and that isn't true. Hospice currently is defined by very distinct definitions, which is driven by Medicare, which is the big financing insurance group, especially when you're older. And so in order to meet hospice criteria, you have to have a prognosis. And it doesn't mean it has to be that number, but an expectation that maybe your life is only 6 months or longer. Or, I'm sorry, 6 months or shorter. And so that is how you qualify for hospice, is that you have some type of life threatening, life-threatening, life-ending disease that may end in 6 months.
Got it.
Yeah, and so it's very specific type of care, and palliative care I like to think is the bigger umbrella term where hospice will fall underneath for sure. But palliative care is the type of care that has similar themes to hospice, but it can begin even at the time of diagnosis. Again, it's not against cure, it can occur together. Can you seek, say, cancer treatment with chemotherapy, but also be focused on how do I treat my pain? How do I treat my nausea? How do I treat fatigue while I'm going through what we would say is curative directed therapy? That in itself is a form of palliative care.
Got it. So you're telling me that a person can undergo palliative care while they're getting treated for their disease. Am I right?
Yes.
And which makes me wonder, so when people are going through such treatment, and usually those treatments can be painful, right? So does the treatment plan change in between, because based on the severity of the treatment the person is undergoing, so they might as well experience more pain during the treatment process, right? So how do you handle that, and how does the treatment process generally look like in palliative and hospice care?
Yeah, I think when we think of there's certain types of diseases that have a lot of protocols, right? Like cancer, I think overall is a good example of like, here you have this type of cancer, here is the protocol. And so you do something that's first called induction, and these are the types of chemos we will use, and this is what we expect to happen. And then when you get through that, you get to do something called intensification, which is like the second part. Like maybe your cancer is gone, but we have to make sure it's gone. And then they go into something called consolidation, and then maybe they're actually at end of treatment. And so like there are a lot of steps, and most people actually get through them, right? But there can always be something that happens, and so sometimes people have to go off protocol, or they have to wait. They can't go into the next treatment yet. And so I think when I think about palliative care, it's like being able to like take a pause like alongside the team and asking questions like, is it appropriate to keep going? Like, what are the risks versus the benefits? Are patients like informed of what is happening? Like, yes, there's a pause. Does that mean, oh, there's just a little pause, it's okay, not a big deal? Or will that actually affect their potential for cure into the future? And I think those are like big questions that sometimes I think people aren't, either because they don't know the answer, or they just like are afraid to talk about that type of I think potential poor outcome.
Thank you for bringing that. And also, my question is, so you're a pediatric palliative and hospice, right? So how do you approach patients? Because patients in this case are children. So how do you approach family and children, and how do you, what information do you tend to seek out of them? Because, how do you maintain patient relationship in case?
Yeah, I mean I love pediatrics, and I always have. I think what is really beautiful about pediatrics is that there aren't a lot of children who maybe have a certain type of disease, and maybe two in the world are known, kind of thing. And so like people are worried, but they don't actually know the future. And so what I love about pediatrics is that even though we may have some data points that point towards, well, like we're concerned, every child that I get to meet, every family that I get to meet gets to write their own story. And so I come from a space of really wanting to be open and curious. And yes, here's some of the data, but we are also learning so much more data. And so what used to be what we would say like is a terminal illness is not necessarily true anymore. And I think we have to be really careful about definitives in pediatrics. I have met so many patients who tell me, when their child was born, they told me my child would die in months, for sure wouldn't live more than a year. And now the child is 5 years old, 6 years old. And so that creates a lot of distrust in medicine, because I can tell you these families will tell me over and over again, well, I remember when the doctor said this to me. And so then they start to become understandably suspicious of anything they're told that doesn't sound, what we'll say is positive, because they've already been told the worst news in the world, which is your child is going to die. And then that doesn't happen. And so now they are not trusting when people tell them something similar again, even though the situation might be different. And so it's really my world of pediatrics is to be really open. Most times they've heard some information, and I say like, the reason you're meeting palliative care is your child has a life-threatening illness. Like, I think most families can grasp that concept that my child is not going to be the typical child. And we're going to be navigating a lot of complex illnesses or different points in our life. And so it would be helpful to have a family that can helpful to have a team that can support us and like help us navigate and ask questions and understand like what is happening to our child.
Thank you so much for highlighting that. Actually, I think you just spoke about something really important, and I see this actually happening in almost like all fields of medicine. I think doctors, they make a hypothesis because you're just trying to help someone here and improve their quality of life and you're just letting them know maybe they may not make it, and and I think people can get a little offended by that because you're just telling that their loved one is leaving them and they might not get a chance. So people tend to defend themselves, like, as in convince themselves that it's not going to happen, and I think that's the first stage of grief. And when it doesn't happen, the first way they try to react is by being angry, and which is understandable, but then also care providers, they're trying to do their best, and I think people should understand that more because all they're trying to do here is help. So thanks for sharing that, Dr. Yip. So could you tell us what kind of diseases are these children facing usually, like if you could give us an example?
Yeah, I think there's so many. I mean, for sure, there's a lot of children that I see with cancer, oncologic disorders, and that can be blood cancers such as leukemia or acute myeloid leukemia. There can be more like bone solid tumor cancers such as osteosarcoma, Ewing sarcoma. We also see a lot of brain tumors such as medulloblastoma, DIPG, astrocytomas. There's all sorts of different types of that, and that's like one group of patients we see. We also sometimes see cardiac patients, so children who have, when they're born, their hearts are just been malformed, and so it requires a lot of potential surgical repair to try and fix them or at least get them more functional. And so those can be pretty intensive times in the ICU, and so sometimes we meet children like that. I think there's like a broader category of children who have neurologic impairment and genetic disorders. And sometimes these are genetic, so they're born with some type of disease that is not allowing their brain to form properly. Or they have an injury either at birth or somewhere along the way in their life. And so that also damages the brain too, and so the function of the brain is affected, and the brain controls everything in our body, right? It not only controls the way you think, the way you communicate, the way you move, but it also affects how your blood pressure works, how you digest food, and nutrition moves through your body, literally to the point of a lot of constipation a lot of these children have because the brain is not talking to the intestines properly. And so a lot of those children live on technology, so that means that they are not able to eat by mouth safely. And so they often have a feeding tube either from the nose down into the stomach, or sometimes they have something more permanent where there's surgery. And so the tube is inserted from the outside of their body through the wall of the muscle and into the stomach. And sometimes they even go further and actually go into the small intestine. And then we have other kids who don't breathe well for many different reasons. Either their brain doesn't tell their body to both breathe in and their lungs to take in air, or they have muscular function where their rib cage won't move properly. And so some of those kids can live with a tracheostomy, which is a surgical tube that's inserted into the neck, which connects to a ventilator. Or some children only need oxygen, so it's just the little nasal cannula that you often see on TV, or sometimes there's higher levels of the in-between, and so high flow nasal cannula is another. I think in the adult world you'll hear things like CPAP. Children can also live on CPAP, and so sometimes they have nasal devices that will do that, or they get it through the tracheostomy. Ventilators can just help provide pressure to help open up the lungs, or they can actually be delivering a mechanism to help people take breaths. And so a lot of the kids that I work with actually live in this world where they're very dependent on their caregivers for a lot of their regular daily life.
Dr. Yip, Thank you so much for, telling all these diseases and what these kids are actually going through, because I think it's really important for people to know how important your job is. And because you help these kids when they're going through the hardest phase of their life, and they might not make it. So thank you so much for, talking about this, and, doing all the great work you do. Keep doing it. And I think we need more doctors like you to, support kids. And it just makes me wonder what really inspired you, or why did you pursue palliative care?
That's such a good question. So the first time I ever considered what I would say is a concept of palliative care is when I was an undergrad. I attended a lecture, like a guest lecture from one of the healthcare clubs that was hosting someone, and his name is Dax Cowart, and you can look him up online. And so he was a gentleman that was in a chemical fire with his father, and his father ultimately dies pretty early. He does not, but he has significant chemical burns all over his body, and he is sent to, he lives in the kind of closer to Dallas, and so he ends up in the Parkland burn unit. And so what happens for his care, this is in the 90s, I think, 1990s. And so he has videos of his treatments, which are really painful to watch. He is screaming and crying and begging people to send him home to allow him to die. That these treatments were very painful. Like he had to do these big wet to dry dressings. I think now I will say that if people have to go through that, there's better sedation and pain management during those type of procedures, but back then there wasn't. And so he wished to not be alive, that he would prefer that over having to suffer this type of treatment. And interestingly, like he did a lot of neurocognitive testing to establish that he was of sound mind and can make decisions as an adult. But his physician, as he tells it, did not want to listen to him and said, like, I know better for you. And so he survives and he lives. And he actually goes to law school. He becomes an attorney. He gets married. And then he becomes this advocate for patient autonomy and decision making for patients. And so he talks about this experience. And of course, I can imagine with this type of point of view, people ask him, why aren't you glad the doctor listened to you? Like, you're alive now. Look at the work you're doing. And he says, like, if I could go back in time, I would still have chosen the pathway of not wanting to continue to extend my life. And I think in that moment, it really gave me pause as to why someone would want to pick that, right? And really wanting to understand, like, yeah, of course I can physically see what's happening, but really to understand him as a human. And that not everyone is going to pick that interventions that may extend their life as much as possible. And why? I think that interest and being curious is what really inspired me to like think deeply more about palliative care, and why does one person make this decision, and why does this person with very similar situation make something totally different. And that's because of their values, like how they grew up, who they are as a human. And that to me has always like inspired me and pushed me into palliative care.
Dr. Yip, that was so profoundly beautiful, and I can't thank you enough for sharing that. Actually, I am so happy that I asked you that question, and thank you so much for sharing that with us. I think a lot of people must have been inspired by your words right now, and yeah. Sorry, what was the name again?
His name is Dax Cowart. So he was an attorney at the end. So Dax, and then I think it's COWART, something like that.
Yeah. Okay. I'll definitely look him up, and I hope my audience found that really interesting as well. And thank you so much for sharing your perspective into that. It was really informative. Also, another question: how was your medical journey like? Because I've noticed that you are actually a doctor of osteopathic medicine, and that's not usually. I mean, if you look at, MD and DO in comparison, MD is a more traditional path, and a lot of practicing physicians, almost like 89% of physicians in the United States, take the MD path, the allopathic path of medicine. So, why did you pursue osteopathic medicine? Why did you choose it over MD? So if you could tell us that, it would be really good, because a lot of students cannot differentiate, as in like when they look at going into medicine, they don't really know what to like pursue, if it should be allopathic or osteopathic. And I think people tend to go for the most dominant one, which is MD, because it's more common. So not a lot of people know what's the difference. So if you could tell us that as well, it would be really informative.
Sure. I think now it's a combined match, so there's less like decision about having to quote pick a pathway. But back when when did I applied a very long time ago. So I honestly didn't have like a preference that I wanted to be a DO, like coming in as an applicant in the state of Texas. All the schools, including the DO school, are on one common application. So I just applied.
Oh.
And I got interviews.
Okay. Oh.
And
okay.
I ranked the DO school, TCOM, which is my school, like it was not my first choice. It was not my last choice. I treated it in the moment as an equal. And so that's where I ended up ultimately. But I will say, I'm really glad I did. And I feel like, I'm I can be a spiritual person. Like, I feel like there's kind of this divine pathway that, like, led me there. And part of that is, like, just who I am. And then how I ended up in palliative care is, like, the tenets of osteopathy as a whole with the founder, A.T. Stills, was a gentleman who was a physician back in the 80s. And then he experienced a lot of tragedy in his life. So a lot of his family died. Like his wife, his children, like everyone just kind of died. And he was really disappointed with the way medicine was, like it had failed him. And so he was trying to, I think in some ways, figure out like something a little bit different, and is there a different way to take care of people? Now he has a lot of interesting, weird things he does. I think medicine has a history of like grave digging and all these things that can be questionable. But like ultimately he comes up with this theory, this concept of like, well, the body wants to be healthy, it wants to be normal, but it's being impeded with kind of this flow state, right? And so if we can help this flow, like that could help the body. Now that sounds a little bit woo-woo. And so a lot of his interventions is something called osteopathic manipulation, which may look a little bit like chiropractic work if people are more familiar with that, but it's a lot of like manual manipulation. What I find that as I've gotten older, that really aligns a lot with kind of Eastern medicine philosophies. When we think of Chinese medicine or Ayurveda, those are much more energy based. There's blood flow, there's lymph flow, I have a Chinese medicine practitioner personally, and so she talks a lot about there's the blood layer, there's the fluid layer, and there's all these different things that they don't, doesn't often align with typical Western medicine. But I find osteopathy kind of aligns better with that there are these states in our bodies where things are kind of stuck, and can we help with that? And so like that is sort of the start of osteopathy. But then like over time it's become much more, what I would say, more towards traditional medicine. And so, you learn OMT, but you don't necessarily have to practice it as a DO. And then DOs are allowed to do MD or allopathic residencies. Like I have a classmate who's a cardiothoracic surgeon. So I don't think it really hinders as much in terms of your desire and where you want to be in medicine. But I do think like we're taught to look at somebody as a whole person. At least that's what I was in my education. And I think that has always, I've always held steady to that. And I'm much more comfortable, I find, with my hands. Like I like to touch my patients. And there's something different between a touch that is, I need to get your blood, like a very interventional touch, versus something that I think has more of a healing intention, right? And that connection to a human that way, I think is really different and powerful.
Yeah. Dr. Yip, I actually loved the way how you look into things. You gave us a lot of example on how, traditional medicine, like, Chinese medicine, Ayurveda, you spoke about all that, and you spoke about how, the body in these types of medicine, the body is looked at as not just like, just an anatomical figure, but also like, it has so many layers to it. And the way you compared it with osteopathic medicine was just beautiful. And I think now a lot of people understand it better. So thanks for sharing that. That was really good. And also, I'm just curious. So again, coming back to palliative care, do you think there are any misconceptions in palliative care that are recurring, that come back on back to you? Because when I look into palliative care, there are some that I hear constantly, like when people, choose palliative care, it's like, they're deciding to be put down.
There are different types kind of on that pathway, like medical aid in dying, which is only legal in certain states. And that is where you still have to have a 6-month prognosis, I think. And the patient will take medication that is prescribed, but they have to take it themselves to end their life sooner. And so that's medical aid in dying. There is another concept you're talking about or I'm wondering if you're talking about, called voluntary cessation of hydration and fluids, which is a little bit of a different concept, where someone who is, I mean, they're usually terminal. Why else would they make this decision? Is that they will voluntarily stop drinking and eating. And so they are allowing, in some ways, the natural process of death, because that's how we ultimately die for the most part. But they're just doing it very actively. That is not, I would say, as restricted in terms of versus medical aid in dying. Like, I'm pretty sure in every state, like, an adult who has the cognition to make their own decisions is allowed to make that decision.
Okay. Okay.
But
But
yeah, so misconceptions in palliative care. I think the biggest one, which we kind of talked a little bit about already, is that when we say palliative care, you are meaning hospice. And then when people look it up online, they'll often see that they're together too. And I think that's just like, it can be confusing. Like, I understand that. And so it's really up to the physician who's presenting the information. So I think be really clear about why. I imagine some people also say palliative care when they actually secretly mean hospice, but they're also not ready to tell patients that they should be on hospice. Sometimes I think that's a reason. I think in pediatrics, it's also a little bit, pediatrics is a little bit fuzzier. Like, children, again, as I said, are a little bit more unpredictable than the adults, generally speaking. And so I think what is also interesting is since the Affordable Care Act, actually children are allowed, if they have a state, federal insurance, so like say Medicaid, they are allowed to both access what we would say is curative directed care and also hospice care at the same time, and that is called concurrent care. So families don't have to choose, they can do actually both. As long as we think the child has some type of diagnosis where we wouldn't be surprised if they died in 6 months, but it is okay if they continue to live past that. So they can often access both. And I think that is really helpful, because why wouldn't you do both? Why wouldn't you try? I think even in the adult world, which I hope things are shifting, well, why can't I take this little oral chemo? Maybe it's going to help, maybe not. Who knows? But if it's not, causing too much side effects, I get to stay at home. I don't have to go to the office to get infusions. I can go live my life. But I can take this medication that could buy me an extra month, 2 months, maybe longer. Why can't I do that and do hospice at the same time, knowing that reality is I might still die? Like, I think it's really unfair to ask people to be all or nothing, because life isn't black and white, right? And so luckily we don't often ask families to make that decision too. So sometimes we are presenting hospice to families, but I think it's this assurance that, like, you're kind of doing both. And if something changes and you don't qualify for hospice, like, that's okay. Like, we'll take you off. We'll happily do that. But if not, and we're starting to go in the other direction, like at least you have those supports in place.
Thanks for sharing that, Dr. Yip, and I think you covered it perfectly. And I just have another question for you. So, when someone comes into palliative care, are they usually really scared, or how do they react?
Yeah, I think families are either scared or almost not confused, but it's like similar to that. They're just kind of like, why are you here? Either, and they're often scared is maybe they've had experience in palliative care or hospice. Like maybe, oh, my grandmother, she was on hospice and they gave her morphine and then she like died the next day. Like I know that sounds a little facetious the way I'm saying it, but that's like a very common story where here's this person, they hopped him up on morphine and then that's all they wanted. They just wanted to end their life is kind of the perception. And so like I think families sometimes come in with that kind of background. And so it's like really important to explore that. Even medication use sometimes. Like the use I like morphine as a good pain medication. It's the gold standard. It's well studied. And people really bristle at it because of experiences like that. But if you say something like, hi, we won't use morphine, let's use oxycodone, which is I think has its own problems in the media, but it's also a very good pain medication. Similar in the same class, can work very similarly. Like people will often they don't associate that with hospice and dying, and so they're much more readily open to that. And so it's often just like exploring with families their experience in quote hospice and palliative care, and then really trying to distill down why we're actually being consulted. And it's hard, like as I said before, when your kid's heart is not normal and they say you will meet cardiology, people go like, yeah, that makes sense. But when they say palliative care, sometimes it's often, especially when I'm meeting families, which can be very early, they're not really sure what we're going to do. And honestly, I'm not really sure what we're going to do. Like this, if I'm meeting a kid in the NICU, maybe they were just born. Maybe people are still doing tests. People are still trying to figure out what's happening. So I don't actually know how I can be helpful to a family either. What I often tell families is like, you're in this big new world now and it's really confusing and you're meeting a lot of new people. Like every week a doctor changes, there's a night person, there's a day person, and it's really confusing to figure out who people are in the beginning. And sometimes, most of the time, palliative care teams are much smaller. They can be more consistent. And so like part of our role is just to be present and be like, just be a familiar face, and if a kid like starts in the NICU and maybe they go home and then they get sick later and they come back and then they're in the pediatric ICU. Like, can you imagine? This is a new world. Who are these new people? And to see a really familiar face, like that can just be so comforting. And so sometimes that's all palliative care is just an anchor in a relationship. And because we've spent so much time with them, we kind of know their journeys and can kind of help shape the story for their teams in the sense of like, well, when this happened in the NICU, it helps, I think, orient the physicians that are taking care of the patient, like, oh, maybe the reason a family is reacting this way or saying these things is because there's this past experience over here that I don't know about, it's been years. And so like being able to kind of continue the storyline of what families are experiencing without them having to do it themselves all the time, I think is really powerful. I mean, that's a lot of work in chronic care. If you kind of look in the chronic care sphere, you'll see kind of people making apps and stuff on like, how do you record your medical journey? And that's kind of part of palliative care, is to sort of be the oral tradition of that, is how I would say. And whether we want to say this or not, like sometimes it coming from another physician who's your colleague has a greater impact than coming from a patient. And I think that's wrong, but it's the reality of things. And so like having this advocate with you to kind of amplify the patient or parent's voice in my case, often I think is really helpful.
Yeah, thanks for sharing that. I think one thing that I see is recurring here is when patients have their own assumptions, like when they're not being transparent with doctors. I think when you mentioned earlier saying, how, your kid is going to die probably in another month or two, but then it doesn't happen really. And, then the parents say, I mean, as in your patient's parents or the patient itself doesn't trust you because you gave the wrong information or something. They question everything around you. I think in both the ends, the doctors and the patients who are receiving the care, they both need to understand that they're just like on the same boat. They're on the same boat, and they're trying to make the best for you, as in the doctors, they're trying to get the best outcome for you. And mistakes do happen because not all five fingers have the same, obviously. And not all treatments are gonna result in a positive way, and not all patient is the same. Their body reacts differently. So I think that's really important, and I think a lot of people need to understand that. Thanks for sharing that, Dr. Yip. You shared a lot of really important points. I had a lot of important takeaways as well. And actually, I have another question for you. You work alongside with Dell's Children's, and you have also founded your own clinic, Moon Rabbit Medicine. And so, could you tell us what inspired you to create it and the vision behind Moon Rabbit Medicine?
Yeah, I think kind of just dovetailing to what I was talking about a little bit earlier is you're totally right, Sai. Like, doctors, nurses, RTs, everyone is just trying to do the good work. And so if you're in the ICU and this patient comes in, like, you're so focused on like what is happening in this moment in the here and now, of course. And oftentimes what if there's frustrations that come up, it may not always be with the team directly. I mean, sometimes it is, but it may stem from like something that was said years ago, and not by those people either. It's just some other doctor somewhere said this, and it is lodged into their like psyche forever. Like, I can't even, I mean, I've had some, I think I said that. Like, I've had a conversation. I can think of a patient now where the mom, I don't know, every like 5 conversations I would have with her, she's like, well, they always said like he should have a tracheostomy, but I don't want that. And like the kid was 18, and I don't think anyone had really talked about a tracheostomy, but it was like, oh no, this one was like, people keep talking about a tracheostomy, but I was told when he was 4 that I should never get a tracheostomy, that I shouldn't do it, that it won't help him. And so like there's these experiences that people have that get like lodged in them, and it's not always helpful. For instance, for that patient, when we finally, it was kind of just like, you need to get a tracheostomy or he's gonna die. Like, those are the decisions now here. And she was like, I'm not ready for him to die. And I'm like, yeah, okay, then it's time to get the tracheostomy. And when they put it in, I can tell you this mother said, like, I shouldn't have waited. Like, it made such a dramatic difference for this patient, right? That she was now regretting this advice she had been given, like, 15 years ago, kind of thing. And so like that is what has inspired me to kind of look into kind of like medical trauma, and I don't think we can prevent medical trauma. I think sometimes you got to do what you got to do to save someone's life. And we're often asking parents to make decisions like as they're literally going through trauma, right? Like, they don't have time to sit here and process. It's now or never. It's do or die decisions. And so like I have so many NICU or prenatal consults is a good one, because like this mom has just had a baby, which is already an experience in itself, and then now her child has this life-threatening disease. There's all these decisions, and like how many times have I seen parents, like mothers, who are just like a month later are just like, I'm now just like being able to process like the delivery, and so like I see that a lot in what I think in chronic pain. Sometimes I think it's like how I got to my clinic, that I see patients who have had to do a lot. They've been highly medicalized from the beginning of their lives, and how that affects them as they get older. And how do you help people through that? And certainly CBT and psychology and therapy are very important. It's so true. A lot of my patients actually do that. They have been told already, you need to do this, and they're like, yep, I'm doing it, and it still hasn't moved the needle as far as they had hoped. And so like a lot of my work is really interested in more of the trauma sphere, the autonomic nervous system, and how your body perceives threat. You know, when we think of, let's say you're walking down a dark alley, right, and you have a feeling, like you've heard the feeling, like the hair on my neck raised up, or there's just like a sense of like someone's watching you, right? Like those type of sensations that we have in our body, like that's the way your body takes in the world. That's how your body will send signals that your brain processes to decide what is this. But we don't talk a lot about that in medicine that way. And so like, yes, psychology is important, but that's a really cognitive top-down approach. And for some people, it's really helping them be able to feel signals in their body and to really understand that in not a cognitive way, but in this like body way, like that's not a threat. So like chronic pain tells you, if you think about it, like I touch a hot stove, I have pain. My body's like, move your hand. That's a protective mechanism. But people with chronic pain have signals of pain that maybe it is something, or maybe it's something that has morphed into not a true pain signal where you're under threat. And so yes, therapy is important, but it's like also how do they understand and feel through that type of sensation is not it's not life-threatening anymore. And so like that has been my focus in my private practice, is helping people do that, or try to heal from that, you know.
Thank you so much for sharing that, Dr. E. Please continue to do this great work that you're doing. Like, all the best to Moon Rabbit Medicine. And you highlighted something really important here as well, talking about how, you know, when a mother, she delivers a kid and then the kid is kept in the NICU and the kid needs to go through palliative, I mean, as in the kid is suffering from something really serious, you know, and the mother actually just delivered. And so I think kids are obviously going through the pain, but I think parents are also like, you know, facing a lot of stress, are undergoing a lot of stress, and they're also under pain from seeing their kids suffer. I think in my previous episode with Dr. Rosenblum, he's a complex care physician, pediatric complex care physician, and we also spoke about the same thing. You know, there is nothing more painful than seeing your own kids suffer and go through something so painful. So I think parents can relate to that really well, you know, because their kid is kept in a box, they're being incubated, and you know, it's just a few hours into the world and they're already going through so much pain, and parents don't want anything else except for, you know, for the kid to live a happy and long life. So I think that's really incredible, like the job you do to ease others' pain and to, you know, give them comfort and make sure they have the best outcome in life. That's something amazing. And I don't know what to say except for just keep doing the great work you're doing right now and continue to help all these children out. I wish them the best and I hope they all make it and they have a beautiful, amazing life. And yeah, thank you so much, Dr. Yip. I had an amazing conversation with you. You highlighted a lot of important points, especially your point on, you know, how that you spoke about a tracheotomy for an 18-year-old and how his mother was a little scared for his surgery and everything, which is completely relatable. I mean, if your child was gonna undergo surgery, of course any parent would be a little scared. And I think parents just believe everything, and you know, sometimes they take suggestions really seriously, and when it's life-threatening, they of course tend to take it extremely seriously, and they don't want anything to go wrong, especially for their kid. Any parent would always want the best for their child. So it's understandable, but it's also unnecessary because the diagnosis doesn't, they were told not to do a tracheotomy like many years ago, but it's 15 years later, the kid really needs it, he needs it. And I think patients should, I mean, as in the parents should trust doctors more, and because everyone wants the best outcome, and doctors also care about their patients just as much as parents care about their children. So thank you so much. I had an amazing time with you. I hope my audience found this extremely insightful. I had a lot of takeaways myself. So thank you, Dr. Yip.
Thank you, Sai.